Hi, Michelle. Michelle?
Oh, we lost her. That's not good
Live stream has started.
Okay, thank you.
Right, I'll get started then. Thank you. Good afternoon, everybody. My name is Jane Francis. I'm Councillor Francis and Cabinet Member of Birmingham City Council. I've been asked to chair at least part of the way this meeting this afternoon because of the unavailability of the leader and the deputy leader. So can I start off by advising the meeting to note that the meeting will be webcast live subsequent broadcast via the council's YouTube site. And the members of the press and public may record and take photographs except where there are confidential or exempt items. Can people in the meeting please, if they wish to speak, raise your hand and use the chat function, and only speak when called to by the chair. And it would be helpful if you switch off your microphone and video when not speaking. Okay, item 2 on the agenda is declarations of interest. Are there any? I'm not seeing or hearing anything, so that will be noted. Thank you very much. Item 3 is apologies. I have apologies received by Councillor Sharon Thompson and Richard Kirby. So that could also be noted.
In addition to that, Chair, I've also got apologies from Andy Coldrick and Riaz Khan.
Okay, thank you very much. Duly noted. Item 4, dates of meetings. And can I share with you to note the dates of meetings of the board for the municipal year 22-23 will be as follows. July 2022 will be a development session. Tuesday the 20th of September and Tuesday the 29th of November. And then going into January 23, Tuesday the 17th of January. So I hope that's acceptable to everybody. Oh, one more. Sorry, Tuesday the 21st of March. My note says that all meetings will commence at 3 o'clock unless otherwise stated. And the time for the development session is to be agreed. I'm hoping that's okay, everybody. Item 5 are minutes, matters arising, minutes of the meeting held 22nd of March. Are we able to get those up, or do we need to get those up on the screen? Obviously, I wasn't part of that meeting, so I've got, I will be reliant on colleagues to accept them or to pick up particular issues.
Shiraz, are there any matters arising that need to be covered?
No, not yet. Not from the last meeting. Yeah.
In that case, colleagues, are you happy to sign those off as a true record of what happened? Excellent. Yeah, very smoothly so far. Chair's update, which I can't do. But, is that something we'll just skip for this this particular session? Fine. Item 8 are public questions, and I have to inform the board that there are no questions from the public for this particular meeting, which leads us nicely on to item 9, which is the coronavirus 19 position and vaccine update statement. We have 10 minutes of this item, and if I can invite Dr. Justin Varney to give a verbal update on this. Thank you.
Thank you, Chair, and I will share some slides which will be put on CMIS later. As colleagues remember that because this data changes, I only provide the slides after the meeting. So I'll just get those up for you. Chair, can I just confirm that you can see the slide deck?
I can see them perfectly, so I assume others can. Justin, thank you.
Great, okay. So as colleagues will be aware, we are still learning to live with COVID, and because of the change in the national testing regime, we are now predominantly relying on a sampling survey, which is done nationally to help us understand infections of COVID, as well as data from the NHS. So the data that is shared in the slide is somewhat historic, because now with the sampling survey, there is a national delay in data getting through to us. This is different from previously when there was a lot of testing and we were getting a lot of very local data. But what we are seeing in Birmingham, as we are across the rest of the country, is that the case rates are starting to come down now quite significantly. But we are also seeing a significant fall in testing rates. And some of the variations we see across the city are probably down to accessibility to testing for people who are symptomatic, as well as motivation to test when people are symptomatic. So it is important we kind of take a degree of caution. But that is also why we are looking at several different data sources, including what's happening in our hospitals, but also the feedback we have from public sector staff sickness rates as well, in terms of keeping an eye on what's going on. What remains consistent and true is that if you have been vaccinated, you are far, far less likely to end up in hospital or intensive care or to die from COVID. And the vast majority of people who are in intensive care with COVID, where COVID is the reason they are in intensive care, are unvaccinated. It is never too late to get the vaccine, and the NHS continues to have what is called an evergreen offer, where if you're entitled to the vaccine, you can still go and get it and you can start whenever. So if you've changed your mind, you now feel comfortable to start the vaccine programme, please go and get it. It is also important to get the booster dose. And what we're seeing is that the booster dose in the over 65s, the more mature members of our city, the uptake is very good. And we're over 80% now in the over 65s for the booster dose. And we're seeing a positive engagement with the fourth dose as well for those over 75. Where it's less good in terms of coverage is people who are clinically at risk. So those are people who've got health conditions, which would mean that if they caught COVID, they're more likely to become severely unwell. And those are the people who the NHS notified by text message during the autumn to say, come forward and get vaccinated. And what I would say to those watching is if you have a chronic condition, if you have diabetes, if you have high blood pressure, if you are carrying a lot of excess weight, please go and get the vaccine. Talk to your GP practice, go to one of the vaccine sites that are available. We know that if you have poor health, you are much more likely to be extremely unwell if you catch COVID. We are seeing the tail end of the deaths now. We started to see the tail end of the last peak working through in terms of death certification. So the pattern is as expected. And this is what we're seeing in terms of the data from the National Infection Survey for the West Midlands. And as you can see, there was a peak around beginning of March. That's now coming down both nationally and in the West Midlands. And they use this kind of surveillance, this sampling methodology to look at what we were seeing in terms of reported positive cases, which is the green line. And then we use the sampling survey to calculate the estimated prevalence, so the estimated number of cases in the community, and that's the blue line. And the pattern is quite similar, but what we're seeing as testing has reduced since the beginning of the year, the gap between those that we know about for sure and those we suspect are there has changed considerably. But the overall trend pattern is the same, which is reassuring. If these two lines were moving in very different directions, then I would be much more concerned about the reduction in testing. Just moving on to the vaccine update, and Chair, I tend to merge the two into each other for time reasons. As I said before, vaccine uptake, particularly in our more mature population, has gone incredibly well. And as you can see, these bars for the 50 plus and 65 plus, in terms of first dose, we're well over 80% and over 90%. Second dose is a similar space. Booster dose slightly behind for the group between 50 and 65, but keep in mind many of those people started their vaccine journey a bit later, and some of them will have caught COVID with the Omicron wave over the beginning of the year, so their third dose will have been delayed because of COVID infection. Where we've still got a way to go is in children and young people. And that, when you look at the overall statistic for Birmingham, that's what's bringing us down. We are a very young city, and in younger children, the COVID vaccine has very, very low risk, but also COVID has low risk. So it is seen in younger children as being a bit more of an optional thing. And therefore, we're not chasing those numbers quite in the same way as we are for older adults, where we are seeing significant impact. I think it's important to acknowledge those of us who are vaccinated and have caught the Omicron, particularly the Omicron 2, which is going around at the moment, will say it is not a particularly nice experience. And I think it's important to remind everyone, if you think it's not very nice if you've been vaccinated, think how much worse it is if you didn't have the defence of the vaccine. So I know many colleagues who've caught Omicron too are saying it really is a very rough flu-like illness, and people are being laid low for several days. And we are seeing the impact of that on our public sector services that are still struggling with staffing issues around the sickness levels that are happening. But I think it is an important reminder that without the vaccine, that could be so much worse. We are very grateful that the vaccine we have is still holding against the new variants. These are the patterns in terms of the unvaccinated population. So the darker the areas of the map, the larger number of people who are unvaccinated. Some of this does relate to age. So, for example, in terms of those that are still to start their first dose, you'll see the area down Edgbaston, which is predominantly has a very large student population who are quite migrant in terms of they're here during term time, they're not, and then they're not. Has caused some issues, and there's been some work the NHS have done around data cleansing to make sure we've got an accurate picture of what's going on. But that is skewing the picture to some extent, and we see that across the city in terms of the younger areas of the city tend to have larger volumes of people unvaccinated, and that is reflecting the childhood vaccination uptake. But I think what is reassuring about this map, although we have areas of the city which are in general a bit darker, what we're not seeing is great chunks of the city that are very, very dark blue with very large volumes of people unvaccinated. And that's a reflection of all the joint work between the council and the NHS. But I particularly want to say the hard work of our GPs and pharmacists who've done over 70% of the vaccines given in Birmingham have been through primary care. And that's reflected in this brilliant uptake, particularly in our elderly populations. As we move through, the pattern's slightly different when we look at second doses, and again, slightly different when we look at the booster doses. We're working jointly with the NHS at the moment around a focus on the 10 wards with the lowest uptake and doing a slightly different model of community development work in those wards to address not just COVID vaccine concerns, but a wider pattern of vaccine concerns, because there is quite a strong correlation between the areas of the city with the lowest vaccine uptake for COVID and those that have a low uptake for other vaccine types. So that's a slightly different approach. As colleagues will understand, we've had over a year of talking about vaccines to communities. So we're trying a slightly different tack to engage with communities in terms of driving up the uptake and closing the gap for those who still remain vulnerable to the COVID virus, particularly with the Commonwealth Games coming. I think it is important that we all do our best to protect ourselves so we can protect ourselves, protect the city, and also protect those coming to visit us for the celebrations over the summer. So I'll pause there, Chair, and happy to take any questions from the board on that presentation.
Thank you very much, Justin. Any questions from colleagues or comments on the information you've just been presented with? Councillor Bennett.
Thank you, Chair. It's just a comment, really. I mean, this is obviously all very positive news, and we've spent a great deal of time talking about COVID for very reasonable reasons over the couple of years. But I'm wondering if going forward we need to have quite this level of information up front at the start of the meeting. I think perhaps we might, it's just a proposal, but maybe we could have it just for information. As obviously, if things change again for the worse, we can revisit that. But at the moment, I just wonder if it's worth taking at the start of the meeting, going through this level of detail, particularly as Justin said, the level of data isn't quite as we don't have the same level of local data that we used to.
Thank you, Councillor Bennett. I'm sure that'll be noted, and Justin is nodding his head appropriately. Anyone else wish to comment or question? In that case, thank you very much, Justin, for that. And I think you're also on the stage for the next item as well, which is the Commonwealth Games update. Thank you.
Thank you, Chair. So again, I'll go back to the slide deck and hopefully take you through a short presentation about where we are on particularly the public health games elements. And just while I'm getting the slides in the right place, I do want to add that alongside what I'm presenting today, which is really around the work we're doing on public health legacy, we are continuing to work with colleagues across the organising committee and the UK Health and Safety Agency around the overall health protection of the Games. The Games provide a unique opportunity for us as a city, but of course there is a small risk that we could have an outbreak of infectious disease, and therefore it's important that we are prepared for that and that we have the right contingency and support in place. But we can bring to a future board a more detailed briefing on that if the board would like. So I just wanted to update particularly on some of the exciting things that are coming to fruition that the board has heard me talk previously about in terms of some of the opportunities that we have to celebrate the Commonwealth, but also to highlight some of the inequalities and focus on particularly health behaviours in the context of the Commonwealth. And colleagues will remember I talked before about the Cook the Commonwealth campaign, working with the WISC partnership, where we are capturing recipes, and I think we're now over 200 recipes from citizens. We're also delighted that restaurants in the city who have Commonwealth heritage and Commonwealth links are starting to donate recipes to the platform, and I particularly want to give a shout out to the Coconut Tree, which has just donated a series of recipes reflecting their Sri Lankan culture. So it's a brilliant free platform to not just access recipes, but also see how you can make them healthier, and often they have some videos as well on how to cook them. We'll be further bringing some of these recipes to life through a series of food and music celebrations. This is a project we've done in partnership with Communities Engage and Thrive, CIC, and there are going to be 10 events across the city, starting on the 3rd of June at the Nietzsche's Pod, celebrating the food and music of Ghana. And we really invite members of the board to come and join us at that. There are further events on the 17th of July. We'll be celebrating the food and music of Trinidad and Tobago at the Simmerdown Festival in Hamsworth Park. On the 23rd of July, we'll be celebrating the food and music of Nigeria at the Birchfield Jazz Festival at St Mary's Church. And there are further events to come which will be coming out over August and into September, which celebrate food and music from Jamaica, India, Pakistan, Bangladesh, Kenya and Sri Lanka. At the events, there are cookery demonstrations, there'll be opportunities to taste the food of heritage, and there are also recipe cards as well as the recipes being part of the WISC platform as well. So I think it's really starting now to come to life. And a key part of this is we've worked with the chefs, and these are all local chefs who will be cooking and demonstrating at these events, to make these recipes as healthy as we can without destroying their taste or their celebration of heritage. And I think that's a really great piece of legacy that we're building through this partnership. Moving on to physical activity, we've now secured the contract and working in partnership with West Midland Legacy to bring Daily Mile activation to 10 parks across Birmingham. West Midland Legacy have a programme where they activate the park through both people being there and encouraging walking, but also creating a series of markings on the ground. So they create a kind of trail that children and families can follow to do their daily mile and to bring people more into contact with the park and what it offers. So I'm delighted to be able to share with the board that that's a project that's been in percolation for a little while, but we've now secured that, and they will be starting to do the activation in the parks across the city over the coming weeks. The Taylor Time Refresh is on track to launch in July. I'm delighted also to update the board that we have now awarded the contract to develop the culturally competent resources on physical activity in 4 languages of Commonwealth heritage, and those will be Punjabi, Urdu, Bengali and Farsi, and the provider has started work on that, so I'll be able to share more details at the next board. We now have health and sport posters that cover all of the sports in the Commonwealth Games, and we're just finalising with the branding team to enable those to be launched, and they will be part of the programme of activity we're working with the ICS on, training up the 1,000 healthcare professionals during the Commonwealth Games to integrate brief advice on physical activity into their daily clinical practice to support patients to achieve their potential. And I'm delighted to share that the first cohort of professionals have started on that training journey, and the team work jointly together, so that I think we're now up to almost 100 have been trained so far. Still a long way to go to reach the 1,000, but brilliant to finally have that out of the starting blocks and moving forward. I've included a bullet on health literacy because we will bring a more detailed update to the next board, but just to say we've launched in partnership with Faith Action, which is a national organisation who had a model on health literacy developed by the Department of Health, focused on children and families. That will be now rolling out in 10 wards across the city, focusing on both English language skills, skills for navigating the NHS, but a particular emphasis on respiratory health. And I think that's a great project that we've been doing as part of our work to recognise and value our Commonwealth communities in the city. So I'll stop there, Chair, but happy to take any questions from the board.
Thank you very much, Justin. It looks like a really interesting programme of activities. Any questions or colleagues for Justin on that aspect of Commonwealth Games? No, very quiet, well-behaved group, this one. If only all mine were like this, we'd be laughing. Thank you very much, Justin. In that case, we can move on to item 11, which is the ICS update. And can I hand over to Karen Helliwell from Salty. Hi there. Hello. Hi, Karen. Nice to meet you.
And you. Thank you, Chair. So I'm just going to give a short update in terms of where the ICS is, and it's probably worth noting that for the clinical commissioning group representatives here today, this is our last final meeting. So for Dr. Taylor, who's the Vice Chair, and Mania, the CCG will be ceasing as an organisation in about 6.5 weeks' time. And obviously we are working very hard now to establish and get ready to put in place the new organisation, the Integrated Care Board. We now have all of our executive team appointed to the ICB, and I can certainly circulate round the details of those appointments, but they will obviously be critical to taking forward the new agenda. So the organisation and the ICS are now working in shadow form. So obviously a lot of the readiness to operate in terms of our governance and our arrangements are getting into place, as you would imagine. In terms of other key areas to note, I think one of the areas of interest, I think, for this board is the identification of a master plan, a 10-year strategy, which is for the Integrated Care Partnership. This is a wider group of stakeholders that are going to be brought together across the system. And I'm delighted, I think, that Justin's agreed to lead the development of that master plan. So there's some real links there with the work already undertaken in the Health and Wellbeing Board. So I think a lot of the work around Birmingham as a place, I'm sure Graham is leading that, Graham Betts, who's on the call, and I'm sure at some of the development sessions, Graham, there will be some opportunities to work through the benefits for citizens. It isn't just about creating the organisation, it is about integrating care for the benefit of our citizens and patients. And I think the focus now will be about improving that care and how we go about it. So I'm sure you'll be hearing a lot more from that agenda going forward. So I wasn't going to say a lot more, Chair. As I say, a lot of it now is about readiness to get established in July, but it feels as you do have a development session, there seems opportunities there to sort of get into a little bit more of the detail later on in the year. Thank you, Chair.
Thank you very much, Karen. Justin has a hand up.
Yes, thank you, Chair. I just wanted to formally thank and acknowledge both Will and Karen and Munir as well, because I think the journey that we've been on in the Health and Wellbeing Board hasn't always been the easy one. particularly through the various iterations of structures and governance and everything else. But it has been one that I think we've travelled as colleagues, and I think it's just important to minute our thanks to them as the journey continues in a new phase for the NHS. But I really value personally your support from all three of you, but also your robust challenge, which has been really helpful in keeping us moving forward. So I just wanted to put that on record, Chair.
That's good to hear, Justin. Robin Miller, hello.
Yes, thank you, Councillor Francis. So I was going to echo Justin's comment to say we're very fortunate, I think, with our clinical commissioning group colleagues in the Health and Wellbeing Board, and they really contributed to discussions and brought a kind of sense of their own roles, but equally we're very happy to engage with others. So I think we were very, very lucky in that regard. And I wanted to ask Karen, in terms of the involvement of people with lived experience of health and social care and communities in the new integrated care system, is that something that you've developed a kind of approach to how that's going to happen in practice, how it's going to work at different levels? And is that something that you could potentially share with Health and Wellbeing Board members?
There's probably quite a few documents that we could start to share. There is a communities and engagement strategy, which we've just been in, Will and I have just been in a meeting to sign off. So I think we're very much looking to the expertise in the local authority for engagement and building on that and partners. I don't think the ICB organisation is looking to do it itself. I think it's really looking to build on some of the work that Justin talked about as well in terms of the vaccination programme and learning. So that's part of it. I think the operating model of the ICB is very much about devolving responsibility and accountability as close to the citizen as possible. And that's a key part of that. And there are various initiatives such as a Fairer Futures Fund, a pot of money, which will be organised and led by the council, by local authority in Graham, to really facilitate that change in communities. So that's a key part of our strategy going forward. And I think in our arrangements, we're very much putting the resources and a lot of our staff, not many of them in the CCG, out into Birmingham. And it's something I've been passionate about in integrating commissioning and working closer with neighbourhoods, which will be a key part of our arrangements. I don't know, Will, if you want to discuss the neighbourhoods, because I know there was a workshop this morning.
There was a workshop this morning about really engaging. You know, the whole point is to have care and integrated care as close to the people and as close to the communities as possible. So really, really thinking about how do we integrate care in those 30 to 50,000 communities in a way where people don't fall down between the gaps between services, which is terrible to say, is what we do see happening now. So, and that key to that is understanding their stories and understanding their voice, because you can't do it without it.
And I think the last point for me is, we're all going into a new system and a new organisation. So clearly West Birmingham colleagues and ourselves are both joining a new system and a new organisation. So we very much welcome that as well. Thank you.
Thank you, Karen. Richard Beacon, and then I'll bring Graham Betford.
Thank you very much, Chair. And just to introduce myself to colleagues, Richard Beacon, Chief Executive from Sandwell and West Birmingham Trust, and my apologies for not having made these meetings before, but I've committed to Dr. Varney that myself or my deputy will attend all future health and wellbeing boards going forward. My question, Karen, relates to West Birmingham, Ladywood and Perry Bar as a locality, which is obviously moving from the Black Country to the BSALT system, and the West Birmingham Partnership Board, as it sort of currently exists, made it very clear what the conditions for success would be. Two of them related to subsidiarity and local determination, and there was an articulation about how that would be sort of measured. And the second being in relation to ensuring that there wasn't, wherever possible at least, essentially two very different approaches to the development of community services in the widest sense between the two parts of the system that my organisation, or two systems should I say, that my organisation supports, particularly through the lens of the new Midland Met Hospital. there is a risk, because there is such a significantly different operating model for BSOL as compared to the Black Country. There is the risk that 2 of the 3 sort of key conditions for success we agreed are not going to be fully assured. Now, they are mitigatable, of course, and we don't need to discuss the detail about how they can be mitigated here. But do you and others feel that that is still a risk? You know, if it is, we've obviously got 6.5 weeks to sort of try to agree some joint statements about how those risks will be mitigated.
Aaron, are you able to respond to that question before I bring Graham in?
Thank you, Richard, for those questions. And clearly there's a level of governance and assurance that is in place to work collaboratively, and I hope we always have, between West Birmingham colleagues and ourselves. So I think I can certainly take that point back through Richard into the ICB with Paul Athy, who's leading on it. But I do feel those risks can be mitigated and identified. If there are still outstanding areas, obviously we will obviously continue throughout the next 6 weeks and beyond. I think there's going to be some ongoing issues as place becomes an entity in its own right in the new way. So I'm sure that we're all committed to that going forward. So I don't think it's a hard end stop. I think there's work that will carry on beyond that. And certainly I think our commitment is we want the right, as I said, services for citizens across all of Birmingham. So that inequity is something we would want to address, I'm sure. I don't know if Graham wants to come in on those points, but there's certainly a big commitment to that.
Yeah, thank you, Graham.
Yeah, thank you very much, Councillor Francis. And yeah, picking up on Karen and Will's points, but I mean, I would focus really on 2 things. I mean, the whole new approach is based on subsidiarity and place, and this is the best opportunity we've had to really begin to transform our services to meet the needs of our communities. And we know in Birmingham, being, you know, the sheer scale of it, we have got 5 different localities. There are, you know, different communities within them. So subsidiarity is a key principle. And what we need to ensure is that the services that are being delivered meet the needs of our local communities, and we need to understand those needs better than we've done in the past. So it is, to me, it's a huge opportunity, both for co-production with communities and community groups, and the opportunity to begin to see services being delivered in different ways. And I think Will was absolutely right. I mean, we're trying to do this in 2 ways. One is to actually begin to build that infrastructure and multidisciplinary teams at a local level. And the workshop this morning was beginning to take us forward in that way. But there is also other work in strategic commissioning, which is very much about getting the right pathways which meet the needs again of our local community. So I think we will want to come back to the Health and Wellbeing Board about both those areas in terms of how they're being delivered in place. The other key element is the interface with the service integrators. That's the main acute trusts and so on, and how they're playing out, how their development pathways. And what will be really interesting is to see how that can interface with place. And that is all to be worked through, and the role of the ICB is to help broker that. I think on the West Birmingham question, in a lot of ways, the reality is, from a Birmingham perspective, I'm thinking particularly about the City Council, there's only ever been one Birmingham. There hasn't been several versions of it. There's been one Birmingham. And again, if you come back to that notion of place, what we're saying is we recognise there are different communities in Birmingham and we need to meet their needs differently. So we were always open and remain open to ensuring we look at best practice, and we can learn from the way West Birmingham as was developed its approach. We can look at Solihull. There's lots of models that we can build on, and really what we're all about, and Karen and others have heard me say this many times, it's about learning from the best, because ultimately that means that our citizens get the best possible services. And I think going forward, that's what we need to be mindful of, and put to one side, what was and what was legal right, what was wrong. Forget that. We've got a great opportunity to move forward now. So, Councillor Francis, what I'll suggest is, I won't say any more than that, but it'd probably be worthwhile at the next meeting to again have this on the agenda so we can give a really good update about where it's got to, how things are developing and improve. Thank you.
That sounds absolutely sensible, Graham, and I'm sure that can be noted. Okay, thank you very much, everybody. We will now move on then, please, so we're nicely on time, to item 12 in your agenda, pages 35 to 56 in the agenda pack. And I'm going to hand over to Richard Beacon, who's going to talk us through the Sandwell and West Birmingham NHS Trust 5-year plan strategy. Thank you, Richard.
Thank you very much, Chair, and thank you so much as well for the agenda time to discuss this. I will keep my comments as brief as possible, but for reference, I think pages 47 to 55 of your meeting pack are the ones that I'm going to use to sort of structure my observations and introduction. So, cutting a long story very short, the Trust had a strategy that had elapsed in 2020 that was largely pointed towards opening the new Midland Met Hospital, which of course didn't open on that date. COVID has happened since that point. The integration white paper has happened since that point. The national NHS approach to collaboration horizontally has happened since that point. And Sandwell and West Birmingham as a trust has slipped backwards in terms of both the regulatory opinion of the quality of its services, but also staff and patient surveyed opinion of the quality of its services as well. So there was clearly a need in the context of all of that to look forward 5 years and try to align what we were doing to the ambitions of both of the systems that we serve. And hopefully this strategy reflects that. From our starting point was really to be clear about what our purpose is. Every organisation really should do that, and we were very clear from the very beginning that we wanted to do more than just be an organisation that treats the sick, because we can quite easily continue to structure ourselves to do that. But by being one of the biggest employers around, and by being one of the biggest healthcare providers around, and by being the host of the place-based partnership in Sandwell already, we've got an ability to do more than that as a so-called anchor institution. So we're saying that our purpose is actually to contribute to improving the life chances and the health outcomes of the two very distinct populations that we serve. We try to keep things simple by saying that we have 3 strategic objectives, the first of which relates obviously to our service users, our patients, and that is because as an organisation that's rated requires improvement by the Care Quality Commission, and as an organisation languishing in the bottom quartile of national patient survey opinion, we have to get the fundamentals of care right, and we are not doing so at the moment. So there is a very structured and very far-reaching approach to continuous quality improvement that we're now launching to get the rock on which we stand to be far more stable than it has been in the last 2 or 3 years. Secondly, we're being very clear that the national workforce crisis could be ignored and we could stick our heads in the sand, or we can accept that the recruitment, retention and indeed inspiration of our clinical and non-clinical staff is going to help us to deliver better outcomes for people. And therefore we're focusing our approach on 4 areas. Obviously culture and how we interact with each other is one of those. But we're also taking the international research evidence from the public sector, which clearly states that staff experience is also heavily influenced by how intuitive the digital technology is that they use, and secondly, by the physical environment in which they work. And there's nothing more powerful than a tweet I saw a few weeks ago that basically it was from an over-exhausted junior doctor who basically said, I don't want yoga lessons. I don't want health and well-being sessions. What I want is a car parking space, somewhere to get hot food at 2 o'clock in the morning, enough colleagues to work with on my shift, and somewhere to hang my coat and hat when I get to work. And focusing on those fundamentals is as much key part of our people plan as is perhaps the more sort of highfalutin organisational development aspirations. Thirdly, and I think probably most critical to this board, is our third objective, which is our population. We're stating the rather obvious statement, but I think it needs stating to a lot of my colleagues in my organisation that we are not an island, and we will only improve health outcomes and life chances for our populations by working with other organisations, both vertically through localities and places, but also horizontally across the two systems that we serve. We do have a bit of a challenge in my organisation because we do serve two systems, so that horizontal partnership with colleagues in Birmingham and Solihull is going to be something that we have to give equal attention to, because 47% of the activity my organisation delivers in patient care contact comes from the Birmingham and Solihull system, and yet we are by the Black Country system.
Yes. Richard, would you forgive me for interrupting you while you're in full flow? I understand that Graham Betts has to leave the meeting at 4 o'clock, so I wonder if your item could be paused and we'll bring Graham in, and then no, you don't need to do that.
No, it's okay. I've asked Carl, who's on the call, to present the report, Councillor Francis. That's very kind of you, but I knew I'd have to go, so I've made alternative arrangements.
Oh, okay. I'm sorry. Apologies then, Richard. I'm sorry.
That's okay. No,
but I've got to leave at 4 o'clock anyway, so I'm just going to leave you all to it. So I beg your pardon. I thought you needed to speak yourself. Right. Back to you, Richard. I'm sorry.
I understand the challenge of doing meeting. I'm nearly done anyway, frankly.
Okay.
I think the job of taking
what anticlimax. Okay.
The conversation, so not a problem. Yep. So what we're saying is, as regards population, there's essentially two elements to our work. The first is that either being a leader in the integration space, as we are in Sandwell, or being a partner in it, as we are in Ladywood and Perry Bar. That's one half, and the other half is an unexplored area that I'm starting to sort of move into, because it's quite clear when you look at, for example, the Midland Met development, its regeneration potential, the Trust's existing work programme around widening participation for some of the more marginalised members of society, and the fact that we have got a massive jump to make in terms of making what we do as an organisation more green and more sustainable, how we can contribute as a so-called anchor institution to economic regeneration, improving the ability to economic participation for citizens. We do not believe we are a leader in that space, wouldn't want to sort of trample on other people's toes, but what we're basically saying to people is we are more than a hospital, and please see us as more than a hospital, because we deliver community services and we have an interest in ensuring that some of the more diverse and deprived communities that we serve, which, as we all know, are some of the most diverse and deprived in the country, we can play a part in helping those people get back on their feet as much as other statutory and non-statutory partners. My final comment is with regard to the Midland Met Hospital. That is our biggest single strategic enabler that will underpin those three objectives that we are seeking to achieve, because it will impact upon each of them, because it will, if we get our care model right, enable us to provide better care in better quality buildings. It will enable us to attract and retain more staff and reduce our reliance on temporary staffing. And thirdly, it will, through developments like the Learning Campus on site in partnership with local universities and colleges, it will give us the opportunity to, as I say, our footprint will be necessarily more overtly wide than it is just as a hospital or a healthcare provider. And then the final slide is lots of boring stuff on how we're going to govern ourselves to drive it, which you don't need to see. And then that was the penultimate slide, sorry. And then page 55 makes it clear what our pre and post Midland Met priorities are. So I will stop there and ask if there are any questions, but thank you very much for the agenda time. It's very much appreciated.
Thank you. We've got a hand up from Justin.
Great, thanks, Richard, and really helpful to bring it to the board, I think. and colleagues, I hope, will appreciate it. I think two things for me that stood out. One was around the ambition around to become more of an anchor institution, and I think that's something where in Birmingham we've got a network of anchor institutions which Claire's support that the board's had previous presentations on. So I think there's some quick win opportunities for us to be able to connect you with that. But also under the ICS Inequalities Programme, there is a specific ambition around increasing the NHS and social care anchor footprint beyond large institutions. So how do we work so that the large anchors connect to medium and smaller anchors, reaching right down across to community pharmacy and primary care practice level, so that we really start to maximise all of those services that are fixed in place because they've got bricks and mortar in a much more coherent way. So I think there's a real offer. There's an offer there, first of all, to do the connection, but I think there's a real opportunity to bring you into the ICS fold in a space which is not just about the place, because I think that's one of the, and I suppose that's my second point, is one of the things that I'm really seeing around the slightly different way of behaving in the ICS is that there is pieces of work really anchored in place in the localities around transforming services. And then where there are things that it makes more sense for us to do across the 1.3 million people at the system level, we are now actually having real conversations about what does that mean. And I think it'd be really wise to have a connection with Richard Kirby about how the Trust connects in to the Inequalities Board and the Inequalities Programme, because I think that's one of the opportunities where the Trust could really forge new ground. Because at the moment we don't have a trust representative for any of the providers other than Richard, obviously, as the Community Trust Chief Exec. So I think there are some synergies there at the system level as well as a place level, and I think some real opportunities. I would say, I think, although some of our NHS anchors have done great work, there is some exemplary work from other non-NHS organisations that we're all learning from in the city. And I think that's one of the real opportunities, particularly from UOB, who've done some really innovative work around place and anchorage. So it's that cross-pollination across the public sector, which I think is key in this.
Thank you, Justin. Robin.
Thanks. Yes, thank you, Rich. That was a really helpful presentation and report. One of the things I saw quite a long time ago about the New Midlands Hospital was that you were going to try and deploy social value through your kind of purchasing and trying to buy local produce and sustainability, etc. Is that still part of the plan?
It is, and we track our performance against it as well. I need to probably cross-reference my numbers, Robin, but for example, I think we said we committed in the business case from 2016 to 60% of the goods and services procured to essentially construct and open the building would be secured from organisations and providers within a 25-mile radius. I think that was the commitment. And that's tracked on a not frequent basis, but on a regular basis through our board committee that's devoted to opening the Midland Met. So I can offline provide the latest performance of that if that's useful. As you can imagine, the unavailability of subcontractual labour because of HS2 and other things that we dare not speak about, and the hyperinflation of materials leading us to sort of look elsewhere globally as well as nationally has perhaps put a dent in that in terms of the latest figures, because our priority now is to get that hospital open. We're providing services on the Dudley Road site, for example, now that are really creaking at the seams in terms of their viability for the 21st century healthcare provision. But I can provide those offline if that will be of use.
No, that'd be great. And just one more, and I suppose linked to that, I suppose going forward, things like catering services, cleaning services, estate services, will there be any engagement, say, social enterprises or those kind of not-for-profit businesses as well? Because there's going to be a kind of long-term sort of commercial footprint that you'll have too.
That's right. So prior to my time, the Trust made a commitment, which I'm just dealing with now, to provide soft FM services via, well, estate services, should I say, estates maintenance services, not soft FM, through a large multinational. However, Catering remains stubbornly in-house. Portering services and cleaning services remain stubbornly in-house and will do so. And the big open space in the new hospital that is the Winter Garden, so-called, that we've already got a partnership with local community groups and local artists, so that it will, and I think, I don't want to sound Johnson-like with this claim, but I think it will be, outside of Birmingham city centre, the largest art gallery space in the West Midlands when it's fully open. So that's just an example, really, of the social values stuff. You know, it is hashtag more than a hospital, and that's what we're trying to push.
Thank you very much, Richard. We have Dr. Aslam. Good afternoon to you. You have a question or a comment?
Hi, Councillor. Thank you so much. I suppose, Richard, it's just to highlight a couple of points that you've already made, actually, and just a plea to Professor Betts as well, is that you said about 45% of your referrals come in from West Birmingham. Actually, from primary care, 80% of our referrals are into City and Sandwell Hospital. So it's a massive part of our referral processes. And it's not just about the hospital, and it won't be just about the hospital going forwards. The integration that we've done with consultants coming into our practices and managing our diabetes better, our respiratory services better, having a gold standard or a CQC outstanding rated palliative care service means that we've got some of the best services in Birmingham. And although the hospitals are challenged, some of the services that we provide for the most deprived populations are some of the best that we've got. And what we don't want to do is unpick the really great work that we've done. We haven't thought about organisations as we've been going along. We've been thinking about actually our patients and the care that we provide to them. And so we just need to maintain a focus on saying that actually those services must stay in place. We mustn't be disadvantaged by moving into, and I agree with Professor Betts, actually, we've always been a one Birmingham place. That has never been different, but the way that our NHS functions and the way that primary care integrates with its hospital is different. You know, University Hospital Birmingham is the main provider for the rest of Birmingham. It's not for West Birmingham. We are functionally different, and it's just a plea to say don't unpick those things, because putting them back together will be very difficult.
Thank you very much. Colleagues, are you happy to leave that item? And I can remind Justin that I've got about 7 minutes before I need to leave the meeting and to formally hand over. Unless there are any other questions, we'll thank Richard Beacon very much for his contribution this afternoon. Thank you.
Thank you.
And I will hand over to Graham for item 13, which is the Birmingham City Council Early Intervention Prevention Programme. And I will say before you start, thank you for being a very well-behaved meeting, and I will disappear at exactly 4 o'clock, and Justin will take over. Thank you very much. Over to you, Graham.
Thank you, Councillor Francis. So we thought it was important that one of the key programmes we've got for transforming the council are brought here, and these huge implications for the work we're doing within the council, for the system as a whole. And I've taken this presentation already to chief execs across the B-Sol system, so it felt it was really good to bring it here as well. And Carl has been leading on this work, doing a really fantastic job of shaping it up, so I'll hand over to her to introduce it to the board. Thank you.
Thank you, Graham, and good afternoon, everybody. I've got a few slides to share with you, but I'll just start off with a little bit of background. So in terms of the council, we have a draft corporate delivery plan for 2022-2026, and we have an ambitious priority within that, which is to move from crisis to prevention. This is also linked to our levelling up strategy and our agendas moving forward in that space. And this is very much based on the premise that if we intervene much earlier, we have better outcomes for our citizens and our communities, and it also costs less as well in that space. So what we've been doing is working on a target operating model for the council as to how we will move into that space. But one of the things that I want to say before I start talking about that is to recognise that this model is rooted within the wider agenda of our partners' priorities and collaborations as well. So it's not a standalone model. You know, I've heard through this meeting all of the things that are happening with regards to the ICS, public health, etc. And you know, it's intended that this programme will complement and support the delivery of all of those priorities. Now, the other thing to notice, in terms of that whole prevention and early intervention space, as a city and as a local authority, we have a decent track record and strengths within this space. So we're not starting from scratch. We have we have best practice across the different parts of the councils and partner agencies, and this includes our voluntary, community, faith and social enterprise sectors, who have also been leading the way both locally and nationally, and also informing central government practice as well. That said, there is still inconsistency in terms of our approaches. We have fragmented experiences for citizens. Our citizens tell us they find it difficult to self-navigate resources. We also have evidence that people don't approach us early, they approach us late, where there's greater risk of poorer outcomes for households. And then, you know, if we place all of this within a post-pandemic world, the cost of living crisis, you know, we're now seeing new cohorts of vulnerable people who are at risk, alongside pressures for those who are already vulnerable. We're also finding that in terms of the universal space, the more vulnerable you are, the more likely you are to find that space not as inclusive, likely to fall through the gaps, not able to access services, and move very, very quickly into that crisis space. And then certainly from a citizen point of view, you know, in terms of aspirations, it's very much that space about being able to live independently, healthy lives, roof, food, fuel, income, all the things that we see important, but also that relational life as well, connected and rooted to and within communities. So what we've been doing is we've been designing a set of principles as part of a target operating model, and we've co-designed this with our partners across the city, and also with input from our citizens and service users as well. We're in agreement that we will take a citizen-centric approach, which supports and builds independence and resilience. We will focus on multidisciplinary integrated offers, which really leverages the strengths of different teams and partners coming together. And what we want to do is empower our officers to get it right first time, either by using, or both by using strength-based approaches in terms of their practice, but also underpinned by strong data as well. And we also want to use data in a secure way to drive and improve both our compliance and our delivery. Then we talk about digital first wherever possible, but this is in recognition of the fact that we need to make a range of offers to our citizens, digital first wherever possible, but also recognising that for some people face-to-face interaction is important, for others a telephone interaction is important. So we need to provide a range of channels for citizens and communities, and hopefully overall have a model moving forward which drives improved efficiency and effectiveness as well. And then we engaged in terms of, you know, the value that this would offer in terms of our citizens, you know, having, you know, supportive local networks, resilience, positive first experience for our staff, being able to work collaboratively, both internal and external to local authorities, and feeling engaged with the organisation and having job satisfaction, through to, you know, the impacts for the council in terms of reduced referrals, reduced statutory demand, and having positive interactions with our citizens and communities. So as I mentioned earlier, we went on a very detailed design phase to date, and we're continuing with that, and we're ramping up the resources in this space as well. But effectively, the first phase was from October, culminating to March the 22nd, whereby we took a report to Cabinet with a high-level target operating model for the council, and I think it's fair to say that we did receive unanimous support for this as a direction of travel for the local authority. So we are continuing with our detailed design, and as part of that, we have identified 2 accelerator projects, which I'm going to talk about in the next slide. But we also continue to identify risks for this programme. This is a massive programme in terms of a culture shift in the way that we work as a local authority. So as you can appreciate, there will be risks associated with that. There's always a risk around resource, making sure that we get the right subject matter experts to support us on this journey, and really thinking about having the right technology architecture to support an EIMP approach. We have different functions, different data sets. Our ITs don't necessarily talk to each other, so that thing around a single view of a citizen is really, really important. So we've got some work happening in the background as to how we bring that together, and that's parallel to the conversations that are taking place in the ICS around shared care records as well. And then, in terms of those mitigations, we are looking at blended teams, bringing in experts from outside of the local authority, bringing in dedicated PMO support, but also bringing in colleagues that we've historically worked with in the space of early intervention and prevention. We've invited our strategic partners from the voluntary and community sector to act as our critical friends in this space, but also provide that gateway into a range of voluntary and community sector organisations, so we can make sure that their voices come through the programme as well. And we also have a dedicated work stream around citizen voice. And then obviously we link across to other transformation programmes as well, and we're working with our colleagues in digital and customer services around the required platforms. But the thing that I want to talk to you about today is 2 of our accelerator projects. So one would be keen to gain your input and support in designing these, but also your feedback as well. We wanted to visit that universal space and those universal capabilities to put in place activities and support which by their nature will enable people to access support much earlier, enable us to get to people earlier as well. So if we look at libraries, for example, people consider libraries to be a safe, neutral space. And there's best practice up and down the country whereby libraries have been utilised to deliver good health and wellbeing outcomes by providing information around health literacy, for example, but also information around income maximisation, jobs and skills, fuel poverty, food poverty, a whole host of issues that bring people into vulnerabilities. And then also a homes and money advice hub. We're looking to pilot a homes and money advice hub, and there's different models up and down the country. And again, this is looking at some of the reasons why people present. Often money and debt is part of the story as to why people present. So that's linked to things like unemployment or low income in work poverty, but also factors like domestic abuse and financial abuse as well. So if you start to look at all of those risk factors together, what we've got at the moment is fragmented services in this space around homes and money advice, and they don't necessarily talk to each other or look at an individual's need in a holistic way. So therefore, having not being able to have a conversation around somebody's debt in a timely manner could result in somebody becoming homeless, for example. Whereas actually, if you brought the 2 things together in terms of homelessness, pre-homelessness advice and homes and money advice as well, and support around how to retain a tenancy, you've got a very different offer. You've got staff working in a very, very different way. And then sitting under those capabilities that we'd like to accelerate and phase in are the enablers which will enable that activity to be delivered. One is about information, advice and guidance. And again, we've got lots of information, advice and guidance from accredited IAG that we have to provide, to IAG, which is part and parcel of a package of support, to IAG that is funded independently or because it's national funding. But nevertheless, whilst it's there, it's not necessarily accessible in a timely manner. So we want to create visibility and coordination around that IAG function. And there's been some research done already which will enable us to start that work. We want to think about community hubs as a model. Now, the good news in Birmingham is we have got so many community hubs in the city. A number of them evolve without any funding from the local authority or our other statutory partners, and they're part of local ecosystems within communities. Now, what we're saying is we don't want to mess with those. What we want to do is to bring some value to those, think about where hubs don't exist, and you know, bring some connections around that, and maybe offer some support in that space as well. We have a contact centre, and this is part of another transformation and redesign programme, but we want to look at that through the lens of early intervention and prevention. If we were to have strength-based conversations, if we were to have longer conversations with people, if we were to really understand the assets within communities, to connect people to the kind of things that Justin was talking about earlier, will it have a different impact for our citizens? So that will be part of the early intervention lens as well. And then I've talked a little bit about a single view of citizens and data. This is going to be absolutely crucial, because what we want to do is we want to be able to identify households before they become at risk, so we get to people early. We also want to understand who our complex households are, so again, so that we're testing, are we providing a coordinated response in that space. But we need to be far more predictive in terms of our analytics around who we target, how we target, even thinking about things like behavioural science and text messaging. We see that in business all the time in terms of how you encourage someone to make contact, press yes, you know, so somebody calls you back. We need to think about those same techniques around when somebody is in debt, you know, rather than saying you're in debt. Text message around, are you okay? Is there anything we can help you with? Is a far more friendlier text than you've missed a payment. So those are the kind of things that we're looking at. As I say, this is all informed by people who are experts in this space, including our citizens as well. So lots of co-design happening at the moment. We've got lots of key milestones that we need to meet, but essentially we are moving towards cabinet with a detailed target operating model and a full business case which will set out the various phases of an early intervention and prevention programme. This is not a big bang approach. This is something that will evolve. It will evolve both internally within the local authority, but also as part of the wider landscape and activity priorities that Health and Wellbeing Board have been talking about today as well. So, you know, one of the asks from us is very much around, you know, how do we ensure that, one, this board is mindful of EIMP, but also that we support your priorities as well. When we're focusing on the design. We're also looking for support around the accelerator project. So we are looking for insight, we are looking for subject matter experts and people who are interested in this space. And you know, any thoughts on any additional partners that should be in this space with us as well. What we want to do is, as I say, build a blended team to work on this, because we are, you know, at the earlier point made around sustainability. We've got to make sure that we take organisations and our staff with us. We build their capabilities as part of the move into crisis, from crisis to prevention. So we deliver to to best effect. So that, you know, we have no illusions about this. This will take time to embed. It will take time to get right. It can feel complicated at times, but we hold dear to that very point in terms of we've got to get those good outcomes for citizens. What we have at the moment isn't working for some of our most vulnerable. We have new cohorts of vulnerability that we need to think about and respond to differently as well. So I shall stop there. I'm not sure if Graham is still on the call.
No, I think he docked off with Councillor Francis, left you to it. Thanks, okay. Cal. So I can see Will's got his hand up first, and then I'll come to Stephen. So Will first.
Thanks, Justin. So yeah, I mean, it sounds like a really comprehensive programme of work that crosses over huge amounts of stuff. A few points really. One is the name's incredibly confusing, given that we've already got a partnership programme with the City Council called Early Intervention. We've now got two. So really we need to think about that, because we can't have the Early Intervention Community Teams, which is a partnership programme with City Council, and this one. When I looked at it first, I thought it was a completely different subject that came on the agenda. So probably worth thinking about that. The other thing, it's really not clear from this how this interacts with place. Things like, that conversation we had this morning around neighbourhood integration, the interaction with health, the interaction with neighbourhood networks. I can't see that from this presentation at all. It feels very much like something that sits within the council rather than something that sits in partnership. Now, that might be just my interpretation of slides, but I haven't seen much in the way of partnership working around this and how it designs into that integrated place-based offer. So I'd just be really interested to hear more about that, because that's so important.
Thank you. Justin, do you want me to respond to that first? Or?
Yeah, it might be sensible, Cal, to just talk a bit, because I know, having been in a couple of the workshops, there's been very interagency, and I know that's not in the slide set, Will, but
yeah,
I can say, having been in them, there have been quite a lot of external partners involved in shaping some of this, but
yeah.
Do you want to respond a bit more, Cal?
Yeah, sure. Apologies, Will. This is the short version of the presentation. We have a programme board for the Early Intervention and Prevention programme, which includes ICS colleagues as well. In terms of the place-based agenda, this will be rooted very much in that place-based approach. So, as I said to you, as I said at the beginning of this presentation, this isn't a programme that is standalone. It is connected to the much broader activities. So, neighbourhood networks, for example, comes up time and time and again. Now, what we do know is there are, when I talked about a fragmented experience, we do know that there are parts of the council that don't utilise neighbourhood networks, for example. So it depends on where those citizens land as to whether they're told about and that they're accessing our networks. So it is about bringing all of those things together. So apologies, we do have a very long-winded slide as well, which probably brings that out far better than this set. And also just the point around the name. Again, you're absolutely right. The reason why we're still calling it Early Intervention and Prevention Programme at the moment is because we are struggling to agree upon a appropriate name for the programme. But by the time I'm hoping that by the time we get to the cabinet report in December, we will have a better working title than the one that we've got at the moment.
I'm sure we will get some new euphemistic title for it. So I'll bring in Stephen and then Doug. So Stephen first.
Thanks, Carl. Really helpful paper, laid it out very well. This sort of talks a bit to Will's point earlier, but I wonder whether at some point this could be thought about in terms of adoption by the ICS and it not just being a Birmingham City Council approach. Well, I appreciate you've done it with other partners. I'm just aware with the focus on health inequalities, there's going to be lots of activity in what is in effect a quite similar space, because lots of the gains are to be made there, and pulling all of this together is likely to give us a better outcome across both programs. So perhaps looking sort of stronger alignment, and then integration down the line would be a useful way to progress.
Yeah, absolutely.
Okay, Doug, do you want to come in next?
Yeah, so for those who don't know me, I'm Richard Kirby's deputy in the Community Trust, and I'm a paediatrician by training. And so my head always spins in these meetings because we feel like we're kind of getting close, and there are so many different elements of this. So the bit that I wanted just to check are you talked about in this being about children, starting off in childhood, but most of it seemed to me to be adult related. Is this actually a life course strategy, or is this largely an adult strategy? Because the vision talked about starting from when we are children, continuing through their life, but it seemed mainly adult related from what I heard from you. That was point one.
Yeah.
I'll stop there and then come back to the others.
Yeah. No, it is whole life course. As I say, it's going to evolve in terms of alignment. So we are working closely with our colleagues around the early help offer, for example, around children and families, and how we align that into this space. This will form part of the detailed design work. We've engaged with colleagues in the Birmingham Children Trust as well in terms of their early help offer. To make sure that, one, we don't weaken the front door around early help, and that we complement and support that space. It is not a adult space exclusively, but similarly we are mindful of the fact that, you know, the factors that bring people to front doors is often related around things like debt, for example, income, domestic abuse, etc. You know, if you look at domestic abuse and we look at the numbers of children in care, and domestic abuse is part of their backstory. So, but by inference, you know, there is a whole life course approach to this, and as we develop the work packages, it will become more clear as to the areas that we focus on across the different cohorts of population.
Yeah. That's really good, and there are a number of hubs, you know. So there are children's centres.
That's right.
There's discussion about something called family hubs, and
and
then there are child development centres. So there are a number of existing kind of bodies which could do with being pulled together for whole families. The other bit was around it sounded like there was almost a making every contact count around homes and money advice, and I was. You know, I've been speaking to Joff, your registrar, about trying to make every contact count. And then there was physical activity and the healthcare practitioners. And there's a number of ways in which, again, we're drawing closer together in terms of a suite of interventions. And again, I guess it's my inability to hold everything in my head at the same time, but just whether we could almost end up with a single piece of paper around all these opportunities and these trainings, and then coming together as a whole kind of workforce, not just across health and social care, but across all of the council and across all the other things that work, because they're coming together, but they're still different elements, aren't they? And then the last one was the library. There was a lot of discussion through the pandemic as we moved to virtual consultations around digital poverty, and there was some work with our Chief Clinical Information Officer with libraries about whether they could become pods in libraries that could be a place where you could do a consultation virtually if you haven't got digital equipment at home. So I just wanted to raise that, and if you want to know more about that, and if I can make that again more live, because it's a guy called John Hyam, who happens to be a dentist, who was doing that work, and I think he's been talking to your library service, but that would be a great initiative.
No, that'd be excellent. Thank you. As we said, any support, any subject matter experts are all very much welcome.
Great. Thanks, Cal. I think that's been really useful discussion. But I shall move us on to the next part of the agenda, which is going to be slightly odd because it's me, but it's only one slide. So this is just an update for the board on the progress in relation to the Black Year report, and where we are in terms of the next steps. And just to get this up for you. So the key point, sorry, automatically goes back to the beginning. I forget to click from the current slide. So the key bits to highlight for the board is we will be publicly launching the public report on the 9th of June. This is your preview of the front cover of the report, but I'm afraid that's all I'm giving you at this point. The full glossy version will be launched on the 9th of June in Birmingham and on the 7th of June in Lewisham. So we're having a week of activation. The further community health profiles will be published over the summer in relation to the African and Caribbean countries of heritage that we commissioned in the autumn of last year. The pilot work on the interventions, there's some interesting learning coming through actually about some of the pilots which haven't worked quite as well as some of the ones that have, and that will be taken into the implementation group for discussion. We'll be working with Councillor Khan, who will ask to say a few words at the end of the meeting, who's our new cabinet member for health and social care, on establishing the implementation subgroup through the City Without Inequality Forum, which Councillor Cotton currently chairs. And we are currently out to tender through the Find It in Birmingham portal for engagement partners. And that's the bit I suppose I wanted to really highlight to the board, that as we said in developing Black Year, it was a new approach to engaging with citizens and with academic partners in terms of co-producing, co-developing responses to the evidence base around inequalities. And we want to continue that engagement moving forward with citizens. So to do that, we're commissioning a engagement partner to work with us and with Black African communities, and a separate engagement partner to work with us with Black Caribbean communities. And that's a direct response to the feedback through the Black Year programme, where those communities said at times we want to be together, but at times we want to be apart, and really recognise that our heritage and our culture is not necessarily the same. And even within the African communities, there are significant differences. So that's where we've separated out the engagement partners. What we also heard strongly through the engagement was that we need to have really focused conversations with young Black men and young Black women. So we're commissioning 2 partners, one to work with each group. So just to ask board members to please help promote those opportunities on Find It in Birmingham, and potential providers can ask questions through the portal. There is an opportunity to ask questions that we respond to, but hopefully we'll get some good providers to work with us. And I know that board members are being sent invites to join us on the 9th of June at the Legacy Centre in Birmingham to launch the report. So I'll stop there and happy to take any questions from the board in relation to Black Year and its progress. Can't see any hands up, which is good. So we will now move on to the next item on the agenda. And I'd like to invite Dr. Mary Orware, who's my Assistant Director of Public Health for Environmental Public Health and Health Protection, to take over to present the Annual Director of Public Health report. So Mary, over to you.
Thank you, Justin. So the Annual Director of Public Health report is one of those reports that is required by the Director of Public Health every year, and this is one of the statutory requirements, but it's an independent report. So in a sense, he gets to choose what topic. Obviously, that's done in consultation with others and with regards to what else is going on in the system at the time. This year, the decision was to focus on the built environment, which we have done, which sort of fits with the amount of work, building work, development work, regeneration that's going on across the city. We have, as part of this, obviously looked at the existing evidence, but we've also done new research to see what does that mean for people in Birmingham. So we've been able to incorporate into this, yes, literature reviews and such standing research, but also the lived experience of our citizens, who have come back with some really interesting findings. Now, the built environment, as you might imagine, spans everything from our homes to where we work, where we play, where we school, and all the corridors in between. So we've sort of focused on a few areas just for this stage. And what I'll do is I'll just touch on those briefly. Should be sharing a slide. Oops, sorry. While that's coming up, the four key areas that we focused on are housing and neighbourhoods. I'm not going to be able to see any hands, so I'll take any questions at the end. So we focused on housing and neighbourhoods, and then we focused on sorry, that's not working.
It was sharing, Mary. There, it's sharing now. We can see it. Yeah, it's gone on to the housing slide.
I need to, can you hear me now? Great. Okay, so yeah, so we focused on housing. I'll just give you the sort of the highlights from each section. Obviously, there's a huge amount of detail within. But from housing, obviously, good quality, affordable lifetime housing. Now, there's a lot packed into just that one line. And I know that there are colleagues across the system who are working on this. But this has been confirmed reiterated by our citizens, our residents, that this is something that's really important to them in terms of the things that contribute to their health. Overcrowding, we know, has been an issue, particularly in the last 2 years. We're well aware of the impact of overcrowding through the pandemic, but it was an issue prior. Fuel poverty, very topical. So there are means to assist people and houses, but there are also additional measures that need to be explored. The private rental sector comes up quite a bit. Now, we need safe, good quality private rental sector. There are constraints in terms of national guidelines as to what can be done to make this happen. And the current measures, we would say, don't go far enough. So there's some further work to do there in terms of making the case nationally for additional powers, but using all the existing powers that we have. There is a need to retrofit, so we need to reduce energy costs, but we also need to have good housing. And so that is work that started this year. I believe there are about 80 homes being worked on. But if you consider that Birmingham has just under 500,000 homes, there's a way to go. And obviously promoting insulation incentives when they're available. No, this is not. Next was neighbourhood and community. Has that moved? So
yes, it has.
It has. Great. Okay. So next is neighbourhood and community. Now, we had quite a bit there in terms of residents wanting us to show that we care and wanting to be involved in the local offer. Now that varies across the city, but we are aware, as we'd expect in certain areas, that the local involvement perhaps is not as great as in others. And that might be where we want to work with communities to improve that. There's a really clear message about increasing the quality of play provision for children. Again, that's something that varies across the city. The 15-minute neighbourhood, I know, is something that is being looked at and was explored even further in the early stages of the pandemic, when people did a lot more of their activity locally. There are advantages to this. It strengthens communities, it invests in the local economy, it helps to build connection, etc. Nature positive built environment. So yes, retaining tree canopy where we can, the use of green space, being able to access things within a short distance of your home. There is recognition that we also have a lot of canals and other blue space of water within the city, and that we haven't always fully utilised this for health and well-being. So the idea is that we use what we have to give health. Yes, some of that will include the choices that people make, but for many people, there isn't a huge amount of choice, and we can look at other ways to improve things for them. The local economy came up, and the local economy interestingly reflects both the business economy, but also, you know, what is in the neighbourhood. So childcare came up quite a bit, and how we could use planning so that if we do have to have businesses, can we get assurances that we'll have healthier catering in the vicinity? There is recognition that the third sector leads in some of the work that we'd want to do here. And so we would, following this report, be continuing that conversation with them. There was recognition also that for a city with so many young people, we need to have lifelong education and skills development. Part of the feedback was that people didn't realise some of the choices they had and the opportunities they had, and some of that was linked to their understanding and in their view, their education. So that was a clear message back from the public. Last but not least is movement and access between the places that give us health. So infrastructure design, including interventions for behaviour. So things that would make us walk that bit more or climb stairs, but also recognising that places of rest, landscaping, benches, lighting, the sense of safety was really important. Public art was recognised. Birmingham's got some great public art, but it's felt that that was not evenly distributed across the city. And public conveniences were also recognised as needing to be available for people if we want them out of their homes and moving around. So active travel we've recognised already. There's a huge amount of work going on there, but that will continue. So that this ranges, as you can see, from the homes in which people live and the places in which people work to how they connect as they go from one to the other. And the annual report is completed now. It'll have its what I'm looking for. There'll be an additional version in very plain English because that is a requirement, and again part of the feedback we've had. And then the next steps will be to take this forward, recognising where action is already underway and where we can make the case for further improvements. I'll stop there.
Great, thanks, Mary. I think the phrase was accessible version.
That's the one. Thank you.
We're working on. So there is because of other pressures at the moment, there's a bit of a backlog on getting accessible PDFs done through the design team. Are there any questions from the board on the report? I want to acknowledge particularly Mary's and her team's hard work in putting this together, because it has been pulled together during the last year of the pandemic. This is one of the two reports that was somewhat delayed, so there has been a huge amount of work while managing other things. But I think it's really helpful. And I think it's also, I'm really pleased that it's landing now, particularly as the council starts to revisit the housing strategy for the city. And tomorrow or Thursday, the Poverty Truth Commission formally launches, and the Poverty Truth Commission will be taking particular focus on housing from the perspective of those living in our poorest communities in Birmingham. So there are some beautiful synergies of timing coming together when it's landing now. So it's some good timing. Can't see any hands. So I take that as well done, Mary, for explaining it and putting it clearly. Shiraz, is there anything we need to pick up on the forward plan?
No, as of now, no. But the next meeting would be a development day. So,
and great, thank you. And just before I bring the meeting to come, Councillor Khan, are you still with us? Brilliant, I can see you just popping up. I just wanted to invite you to say a few words to say hi, because I know you've been observing today's session.
Thank you. Thank you, Dr. Varney. Good afternoon, everyone. And thank you for the introduction. Yes, so I have been observing and I've really enjoyed observing this meeting. I found out that I would be the new Cabinet Member for Health and Social Care just yesterday, and I was very keen to sort of get hands-on and try and learn as much as possible, as quickly as possible. So I have enjoyed attending this meeting as an observer. I'm not going to say I understood all of it. Some of it just kind of went way over my head. I tried my best to follow through. I had the papers in front of me, but I just want to say that I will be spending the next few weeks in just getting to understand the brief, and ideally learning from all of the people that I've got around the room. And I'm very keen to meet with as many of you as possible, just to use your skills and expertise in equipping me in my role as a new cabinet member. So yeah, I'm really looking forward to working together with not just obviously the officers of the council, but also the external partners. And I, I'm very keen to working closely, and I definitely welcome any guidance from yourselves, who are really the experts in the field. So thank you for sort of having me as an observer, and I guess until next time, I'll be chairing this board, I believe.
Yes, I think you will, Councillor. I'll be happy to move back to my officer status completely. But thank you very much for joining us. We haven't got any items of any other urgent business that I've been notified. I'll just check. Can't see any hands going up. So thank you very much. Oh, Robin, you got in just before the hammer fell.
Sorry, thank you, Justin, and welcome to our new chair. So a very minor point here, just people may know that one of the great academic traditions is when you become a professor, you get to give an inaugural lecture. And mine was somewhat delayed due to COVID, but it's going to be on the 6th of June, and it will be about collaboration and leadership, which clearly I've drawn a lot from my experience in the Health and Wellbeing Board. So I know it's slightly frivolous in any other business, chair, so do please forgive me, but you'll be all very welcome to attend. It's going to be at the Exchange and also online, and perhaps we could send around details, and it'd be great to see you there. Thank you.
Great, and congratulations, Robin. I think having been to Professor Emma Free's inaugural lecture, I really recommend them to colleagues. Actually, it's really interesting. It's also lovely because you get to hear all of Robin's history coming out, because the professors share their journey. So, Robin, if you can send around the details to Errol, we can make sure they're shared with board members.
Thank you.
That'd be brilliant. Great. Well, thank you very much, colleagues. And I will happily give you back 25 minutes of your day. So have a lovely evening and enjoy the Birmingham sun. Until next time.